Welcome to another Pomegranate Case Report, developed by trainees of the Royal Australasian College of Physicians. Today's case was published as a Lessons from Practice article in the Medical Journal of Australia from 2020. There's a link in the show notes if you want to see the associated imaging for yourself, but to test yourself without spoilers, just sit back and listen to the exposition from series host Dr Stephen Bacchi. He's an advanced trainee at Lyell McEwin Hospital in Adelaide. As well as his special interest in neurology, he has a commitment to medical education and is currently undertaking a Fulbright scholarship in the USA.
Hi everyone, thanks for joining us. My name's Stephen, I'm a neurology registrar at the Lyell McEwin Hospital, and today with us I have Dr Andrew Vanlint, who's a clinical haematologist and general physician working as a medical education consultant at the Lyell McEwin Hospital. He's also a lecturer at the University of Adelaide and undertaking a master's through Flinders University. And with him I have Sarah Fu, who is a basic physician trainee at the Lyell McEwin Hospital, who has an interest in infectious diseases. Thanks for joining us.
Great to be here.
Thanks, Stephen.
As previously, we'll be discussing a published case report in a step-by-step manner with a focus on content that is relevant to trainees and our generalist audience. Sarah, could you please introduce the case?
Sure. So in this case, we have a 14-year-old male who presents with 3-month history of non-bloody diarrhea, accompanied by abdominal pain and 8 kilograms of weight loss. Of note, he had a history of recent pulmonary edema, abdominal lymphadenopathy noted on a computed tomography scan 3 years ago, and polyarthralgia for the last 5 years. Now, that's a bit to unpack in this scenario. Dr. Vanlint, what would be your approach to the differential diagnosis in this case?
Great question. And this was a very unusual case. And I'll give a little bit of narrative along the way. This was in my third year of BPT at the Queen Elizabeth Hospital. So post-exams, I was on gastro, and this was referred to me from the acute medical unit. I think when you kind of outlined it like this, it's good to think about the individual symptoms and then to think about, are there any kind of Occam's razor unifying diagnoses? So we've got more of a subacute presentation of diarrhea, and it's helpful to think in terms of infectious causes. It's probably not going to be viral, but something could be a prolonged bacterial infection. It could be something more parasitic or an unusual bacterial infection that is a more subacute chronic. It could be inflammatory, especially because it's been going on past the acute phase. So inflammatory bowel disease or other inflammatory disorders would come to mind. And then it could be malabsorptive, which obviously crosses over with inflammatory as well. It's a bit unusual to have those kind of malabsorptive and inflammatory conditions kind of appear suddenly in somewhat middle-aged men, but it can happen. So then the next one is abdominal pain. It's really broad, and we don't know with the pain, is that more acute or is that accompanying the diarrhea? I think the timeline, the character and the severity are really important to get a clearer differential. So very broad, lots of different things that can cause pain, which I won't cover in detail. Weight loss, definitely, both as a general physician and hematologist, whenever I think about weight loss, I'm thinking about malignancy. But in this case, I'd also strongly consider whether the diarrhea and associated malabsorptive issues from the diarrhea, whatever the cause may be, is likely to contribute to weight loss. So that would be my natural bent, is to attribute to the diarrhea until I prove otherwise. But then, of course, this could be a unifying diagnosis of some kind of chronic infection that is both causing abdominal pain, diarrhea, and contributing to weight loss, independent of the diarrhea or in combination. So that's what I'd be thinking in terms of the weight loss. The pulmonary edema is the particularly unusual feature here. And I do want to comment on that. There's a 48-year-old, he was very fit and had no other very significant past medical history beyond the arthralgia and lymphadenopathy that's been mentioned. So this was very strange. Approaching this again, I'd be thinking, is this an unusual manifestation of heart failure from maybe more of a genetic or inherited form of heart failure, like a dilated cardiomyopathy or hypertrophic cardiomyopathy, and it just hasn't kind of reared its head yet? Could this be a myocardial infarction with an acute heart failure precipitant? Could it be a pneumonia or some kind of acute lung infection precipitating that edema as part of that, more like an ARDS type presentation? So that's a bit unusual. It seemed very brief and had resolved and it never happened previously, so I wasn't sure what to make of it. Even now, I'm not 100% sure how it fits into the scheme of things. Then you get what I think is always more interesting, lymphadenopathy. So this is definitely a chronic lymphadenopathy, and that instantly rules out the more acute infections that you would get localized lymphadenopathy from. So obviously we needed to check, is that still present now? I think it said 3 years ago it'd been watched a couple of times and seen by one of my senior colleagues in the clinic, and they hadn't biopsied it. Definitely an indolent non-Hodgkin's lymphoma should be considered. Follicular, mantle cell, a chronic lymphocytic leukemia can also cause chronic lymphadenopathy, and they can be reasonably dormant or very slowly progressive. They don't have to be rapidly growing unless they're acute. And then you can think of things that are less common but can cause lymphadenopathy. And I think of things like Castleman's disease and IgG4 disease. Neither of these completely fit with the other symptoms, but the fact that you've got this kind of chronic lymphadenopathy means you need to expend your differential to these less common inflammatory disorders that are there. And then lastly, you've got this polyarthralgia. Is this just pain? Is there arthritis there? That's not really clear. Definitely rheumatoid arthritis, osteoarthritis, then less common things like lupus, or rarer things like connective tissue disorders would be amongst the differential there. So that's how I'd probably unpack the individual ones and go, what are the common themes here? And probably the common themes we're seeing here is some kind of chronic infection, or maybe some kind of inflammatory or malignant disorder. They're probably my top three that would potentially unite these things, but it's not 100% clear.
Well, thank you for that thorough dissection of a complex presenting complaint. So now we have additional information. He has previously had BCR-ABL tested, which is negative, and a negative serum protein electrophoresis. But today, on examination, it's essentially unremarkable. So with further investigations, he has a complete blood examination that demonstrates a microcytic anemia and an elevated C-reactive protein of 168. Now, there's a few possible causes for this anemia, but in the context of the patient's presentation, I was wondering about an anemia associated with malabsorption or an anemia associated with chronic disease. Could you please explain how you'd approach this anemia and distinguish between such possibilities?
Yeah, absolutely. So the first two tests, just for those that are less familiar with them, so BCR-ABL testing is for our stock standard chronic myelocytic leukemia. There are atypical forms of CML that are not BCR-ABL positive, but they're pretty rare. So I don't know that was needed. CML's not associated with lymphadenopathy, but anyway, someone's done it. It's definitely not CML. Wasn't thinking it was CML anyway, but that's fine. Then SPEP is serum protein electrophoresis. It has a few other different acronyms that can describe it. And effectively there you're looking for a monoclonal gammopathy. So some antibodies, and IgG and IgM and IgA most commonly, that can be associated with myeloma, can be associated with lymphoproliferative disorders, particularly things like marginal zone lymphoma, can be found in CLL, always found pretty much in Waldenstrom's macroglobulinemia. So we're not seeing that at all. So that's just ticking off another thing. So it's definitely not a plasma cell, or it would be very unlikely to be a plasma cell disorder as well, which are known to cause anemia. And all of those other things I mentioned can be associated with anemia, either from direct involvement with the bone marrow or from secondary effects. So in terms of the anemia itself and delineating between what you've put there, I mean, microcytic, you're always going to think iron deficiency. If it's pretty much been lifelong, think about thalassemia. I don't think that's what we're dealing with here. I think he's had normocytic anemia and then non-anemic previously, so that's probably ruled out reasonably, and I wouldn't go with hemoglobin electrophoresis in that setting. Then you can get heavy metal poisoning, which is rare, but does happen in some places, even in Australia. So lead poisoning would be the classic one for microcytic. If you're not from Port Pirie or particular areas of the Northern Territory, that is very rare. So this person was not. So I wouldn't be following that one up. So the key here in terms of, is this stock standard iron deficiency or is this anemia of chronic disease, is the iron studies, mainly for the transferrin saturation. So if the transferrin saturation is down and the ferritin is down, that's just your stock standard iron deficiency. If the ferritin is normal or elevated, perhaps from inflammation, but the transferrin saturation is less than 20%, and particularly if it's less than 10%, then that's going to fit really nicely with anemia of chronic disease. and particularly those that have a ferritin that is normal but below 100 and transferrin saturations below 20. Those are the group that have probably the best evidence that they benefit from IV iron infusions for managing that, whilst the ones that have higher ferritin have questionable benefits. Not that you can't do it, but it's probably not as black and white as that particular subset with the ferritin below 100.
Excellent, thank you. So we don't have the information about the iron studies, unfortunately, but we do have a repeat computed tomography of the abdomen. It showed a stable mesenteric and retroperitoneal lymphadenopathy with splenomegaly. However, the lymph nodes were found to have abnormally low fat density hypoattenuation. Acknowledging this is a podcast and the scans are available in the article, could you explain to us what low attenuation lymphadenopathy is and the types of conditions in which it might be seen, and how would it affect your workup?
Yeah, so this was a really, I think we named the case report in this way because this was one of these hallmarks that led to the suspicion of the diagnosis in the end. And I had a vague idea of what attenuation was, but I had no idea of the very specific differential that arises from low attenuation lymphadenopathy. So just to revise, attenuation is the reduction of intensity of an X-ray beam, which is the same for CT, as it traverses matter. And I think in one sense, this is not completely true, but in one sense, it's a surrogate of density, of like kind of radiological density. So it doesn't actually have to be dense tissue, but things like calcification and bones have a very high attenuation. And things like fat and fluid have a very low attenuation. And soft tissue sits partway in between those two extremes. And there's some exceptions in that if you give IV contrast, that's obviously a fluid, but it will attenuate the X-rays really strongly, so it will look potentially even denser than bone does. So that's why I say, in one sense, think of it like radiological density, and there are some things that are radiologically dense without being physically dense. These nodes are effectively that less attenuated, less radiologically dense than other soft tissues. That's the definition of low attenuation. It has to be lower than the soft tissues around it. And that, in a really basic sense, it's either because they have more fluid or necrosis, because necrosis will produce swelling and fluid in there, so cystic or necrotic features, or because they have more fat, because fat has more fluid as well. And if you think about things that might cause that, fluid and necrosis can be found in some lymphomas. So it's not to say that low attenuation lymphadenopathy is lymphoma, it's just saying that some that have more cystic and necrotic features will fit this particular definition. Metastatic disease does not typically produce low attenuation lymph nodes, but they can, again, if there are necrotic or cystic components to it. And then there are rarer inflammatory disorders that cause this picture, like the well-known Kikuchi-Fujimoto disease, which of course Sarah and Stephen know very well, and I definitely didn't just revise that last night. And then on the latter one, in terms of fat, fat's associated with things like Whipple's disease, and it can be other fatty disorders like a myelolipoma that's outside of the typical tissue that you find that in. So in terms of like, is it low attenuation or not, that wouldn't really, as a hematologist, make me think it was or wasn't lymphoma. I think if it's warranting a biopsy of its own accord, then this particular report feature won't sway me to do it more or to do it less.
Great, thank you. And in this instance, the treating team, possibly yourself, considered Whipple's disease a possibility in that context. And this was subsequently supported following endoscopy and colonoscopy, which showed PAS, periodic acid shift staining, and Trophorema Whipway positive polymerase chain reaction, or PCR. The patient had a prolonged course of ceftriaxone followed by trimethoprim sulfamethoxazole and had substantial improvement. So what a diagnosis.
Yeah, I'll add a bit of narrative to that. So this was a Friday afternoon and one of our registrars was off sick, and I don't usually hold the consult phone. And we got a call from AMU and they'd said, look, there's this gentleman with this description of what we've talked about at the beginning of this case. And the radiology report from the CT that was done just 2 days before he came in as just part of his monitoring of the lymphoma had been done by a colleague, and he was preparing for his radiology exams and was clearly feeling very academic and had written this low attenuation radiology lymphadenopathy comment and then said, think about lymphoma and infection, but consider rarer options such as Whipple's disease. So with that, I was like, oh, Whipple's disease. I remember studying that for my exam. Let me brush up. And I will recommend the up-to-date article on Whipple's disease is honestly a really succinct and great, easily read summary. And I can't say that of every up-to-date article. It's a really nice one. So if you're wanting to read about it, I'd recommend that. And it clearly said there are these 4 main features that they have, which is diarrhea, abdominal pain, weight loss, and then with a potentially months or years long history of a seronegative arthralgia. And I was like, whoa, radiologically, we've got a feature. Symptom-wise, it fits. It probably isn't. This is a condition that only happens to about 30 to 40 people in the world per year. It's very rare. And there's probably only something like 700 or 1,000 recorded in history. This is a very rare disease. And I then went and saw the patient. He had all the classic features, and I managed to convince our afternoon endoscopy consultant to do an endoscopy, and it found these plaques basically in the stomach, the small bowel, and the large bowel, which typically they say the GI is affected from the lower esophageal sphincter to the anus, and this is exactly what we saw. And no one in the department had ever seen these plaques before, but we Googled endoscopy Whipple's disease, and it looked exactly like that. And so we were pretty convinced. And then subsequently, I went and sat with the pathologist, and he was excited without showing a lot of excitement in a probably stereotypical pathology way, in that he said, oh, this is a really interesting case. Hey, look at this textbook that I pulled out. Physically showed me the textbook picture. And he goes, look, it's almost exactly like this slide. And so that was the PAS-D staining. And then the PCR came back later in the week as positive. And we started the ceftriaxone. This is a usually very fit guy. And with the next day, with only 1 dose of ceftriaxone on, his diarrhea stopped, the cramps went away, and his appetite returned. It was like a remarkable difference. And he subsequently went on to a year-long course of Bactrim, which worked really well. So that's the narrative there.
Thank you for sharing. Could you please give us more of an overview of Whipple's disease?
So like I said, these 4 main symptoms, diarrhea, abdominal pains, particularly cramps, and weight loss, and this precursor or heralding arthralgia, which is seronegative arthritis type presentation. It's typically a migratory polyarthritis that sounds like rheumatoid, but you won't find any markers that are positive. And it typically happens in middle-aged men from Eastern Europe, and this guy was a middle-aged man from Eastern Europe who returned to Eastern Europe once a year to see his family. It'd actually come on after he'd returned earlier that year. So what we understand from this is if you do all these samples, there's this infection of Trephorema Whipplei, which is named after Dr. Whipple, who described this, different from Whipple's procedure. That was a surgeon. This guy's a pathologist, both in America. Some say they may have met or may not have met because they lived at the same time but different parts of the country. And trophe is to grow, and erema is barrier. So the classic description is these people just waste away without treatment and subsequently die of cachexia. So that's where it's got its name from. We think, because if you measure these people, it's a very small number of people that have Whipple's disease. They respond very well to antibiotics. It seems like they're colonized throughout the bowel and many other organ systems, and the immune system does not fight it. And it does produce some paraneoplastic, almost like symptoms that we think are an indirect component of the immune system being dissuaded from fighting it. So we don't know whether there's a genetic disposition in this particular cultural group or ethnic group that prevents the immune system recognizing it, or maybe the bacillus itself down-regulates the immune system and therefore evades it. Really interesting. There's not enough cases to do proper research on it, so maybe we'll never know. We won't know for a long time. In terms of the other features, other than that classic 4 that I discussed, fever occurs in 40% up to. Endocarditis, which can occur separately from Whipple's disease classic or as part of Whipple's disease, is another manifestation that's important. And actually, a study of culture-negative endocarditis where they'd taken out valves showed that Whipple's disease was the most common unculturable infection of those valves, which is really interesting. That was only 6%. So there's a whole lot of other infections that they could find on microscopy, but they couldn't culture in the blood. Rarely pericarditis, myocarditis. If it gets into the brain, it can cause dementia, and it can cause skin hyperpigmentation, and then a few rarer pulmonary manifestations like pleural effusions, interstitial lung disease, and pulmonary hypertension. And we did wonder whether that little flash APO thing that had happened a few weeks prior was some kind of lung manifestation. But regardless, these patients usually respond really well to treatment, although it can be difficult, and a decent number maybe 20 to 30% of people will relapse after completion of treatment, need to go back on long-term treatment to properly clear it.
Perfect. Now, to wrap up the case for our listeners, could you please outline a couple of key learning points or take-home message that you took from the case?
So I thought of three things. Firstly, this is a great example that multidisciplinary collaboration always value adds to patient care. Sometimes it's a bit messy, but it's well worth it. So this was a great collaboration between acute medicine, gastroenterology and radiology, and three of those disciplines contributed to writing up the article, and obviously a little bit from pathology and hematology in the background as well. Without that collaboration, without it being specified in Marco's radiology, particularly academic radiology report, we may not have got that diagnosis. We may not have pushed for an endoscopy. Probably he would have got endoscopy at some point, but we got that diagnosis quickly and he got a quick response from treatment because of that. So I'm grateful that he was sitting his exams at that time. Secondly, Whipple's disease, it's rare, but it's probably under-recognised. And so 4 features, as we've recommended, and those rarer manifestations. Interestingly, even though it responds to ceftriaxone and Bactrim, there are a range of antibiotics that it will respond to. So this guy had some Augmentin for about 5 days, about a month prior to coming in. And he noticed that when he took the Augmentin, the diarrhea resolved for about 5 or 6 days. And then a few days after he stopped the antibiotics, it came back again. And so in retrospect, we think that was the Whipple's disease responding temporarily to that antimicrobial therapy. And lastly, lymphadenopathy, it's easy to go, oh, maybe it's lymphoma, maybe it's metastases or local infection. But I think this case and our discussion does highlight that there are some less common but important differentials to consider when you've got lymphadenopathy, and whether it's acute or chronic will make a big difference to the way you consider that.
Fantastic. Thanks, Dr. Vanlint. And again, what a great diagnosis. So for people who want to read the full details of the case, it's titled Low Attenuation Lymphadenopathy on Computed Tomography Leading to Diagnosis of Whipple Disease. It was published in the Medical Journal of Australia in 2020. The first author, Dr. Andrew Vanlint, who's joined us today, and senior author, Sam Costello. Thank you again, Dr. Vanlint.
Great to be here. And I also want to acknowledge one of my co-authors and who was on AMU at that time, Patricia Kazan, who's gone on to become a gastroenterologist who contributed to this article and the diagnosis as well.
Thank you so much, Dr. Vanlint, and thank you everyone for listening.
Thanks again to Stephen Bacchi and Sarah Fu, 2 physician trainees who have volunteered to produce this educational resource for their peers. They do both have day jobs, so please take this podcast as a prompt to read more, rather than the authoritative last word on the subject. As well as these case reports, there are a few different podcast formats published under the Pomegranate banner. IMJ On Air showcases authors who have recently published in the Internal Medicine Journal, flagship publication of the Royal Australasian College of Physicians. The Journal Club episodes feature college members who have presented impactful research in other publications. In both cases, I have guest hosts with specialty expertise driving the interviews for me. And you'll also find some episodes labelled Guest Lecture. These are presentations from college members that I've spotted through other academic institutions and thought were worth sharing more broadly. The podcasts that just have a number in the prefix are the more produced documentaries about the culture of medicine, which take a bit more time to come together. I'd love to hear your suggestions for any of these formats via the email address podcast@racp.edu.au. And get your colleagues hooked by subscribing to Pomegranate Health on their mobile podcasting app. Some popular options are Spotify, Castbox, Apple Podcasts, and Overcast. But for late adopters, there's also an email alerts list that can be found from our landing page, racp.edu.au/podcast. And don't forget all the other online resources at elearning.racp.edu.au. For trainees, there is the College Learning series containing hundreds of detailed medical lectures. And then in the Medflix channel, there are lots of special interest webinars from outside the core curriculum. This podcast was recorded on the lands of the Kaurna and Gadigal clans. I pay respect to the elders and teachers of many thousands of years. I'm Mick Cavazzini. Thanks for listening.